trial and error prescribing means at least 1 in 4 prescriptions is ineffective, unsafe, or both. These medication failures cost a huge multiple of the drugs themselves. So maybe high drug prices is the wrong issue to chase. Hi, everyone. I'm David Williams, president of strategy consulting firm Health Business Group and host of the Health Biz Podcast, a weekly show where I interview top healthcare leaders about their lives and careers. My guest today is Travis Morgan, president and chief financial officer of DecisionRx, which optimizes medication therapies. If you like this show, please subscribe and leave a review. Travis, welcome to the Health Biz Podcast.
Hey, David. Thanks for having me.
I can't wait to talk about optimization of medication, although I can wait because I want to hear a little bit about you before we start talking about that. Maybe starting with what your childhood was like and any childhood influences that have stuck with you throughout your career.
Yeah, so I grew up, both my parents were pretty entrepreneurial. In retrospect, that probably instilled in me a sense for unconventional thinking and challenging the status quo, I suppose. They were never very successful as entrepreneurs, so it also instilled in me the importance of understanding finance and accounting and business. So I went to undergrad, got degrees in accounting and finance, launched my career as a CPA, working for KPMG, and went to grad school and have spent, since grad school, spent my whole career pretty much in private equity as an investor and an operator, primarily in life sciences companies. So
that sounds good. So I saw in your education, you did your undergraduate, you did your master's as well in the U.S., but also looked like you went sort of to various continents for other studies along the way. Were you trying to get away from something, or had a specific interest in the other lands?
Just scratching my itch for curiosity, intellectual curiosity, and seeing as much of the world as I can when I was young.
I always enjoyed traveling around actually in my youth and seeing some of the economic interactions going on, just even how people bought and sold things in stores, if there's, negotiation versus a fixed price, if people are customer service oriented or, just look at it as, just their job to do whatever and mind the shop. Did you find those sort of things when you were, I think, both in South America and in maybe Northern Europe?
Oh yeah, for sure. Especially I was in Europe in the early '90s, right at the time of the EU, and it was a study in finance and economics, right, as they navigate that whole transition to the common currency, and it was a fascinating time to be there for sure.
And one of the things you get an appreciation for, I think, in the U.S. is that almost any market niche is kind of big enough to go after. And if you look and you say compare that with another economy, even if the GDP per capita is the same, but if they have 100th of the people or a 50th of the people, these niches don't actually support real businesses like we would be interested in. So it did develop a definite appreciation for the U.S. market from that.
Yeah, it just gives you a completely different perspective on scale and culture.
So I saw, variety. You mentioned KPMG, but a number of places that you work. Could you highlight a couple and go into few specifics about kind of what you learned along the way, or any specific turning points that you had?
Well, a lot of my focus has been in the diagnostics space, and so co-founded and ran a couple of DNA labs, which I think provide a unique perspective on healthcare and precision diagnostics. And generally, we built a fairly prominent DNA lab focused on specimen provenance and patented some technologies around the whole precision medicine workflow. And sold that a few years ago. That combined with experience investing in and running health tech companies and understanding data science and AI and ML applications. It's really the combination of those two lenses that made the current business DecisionRx such an obvious opportunity.
So when did you get started with DecisionRx, and did you have partners to get that going?
Yes, we launched DecisionRx in 2022. It was effectively a spin out of a technology stack that had been in development, sort of incubation for some time at a portfolio company that we had. I did have a team of partners that co-founded it with me and got it launched. And really, DecisionRx is the embodiment of, or the convergence, of clinical science and data science to solve a very specific and important problem in healthcare, which is how we manage medication therapy.
So how do you think about, going up to the top where they often say, I think the most expensive, medical device is the physician's pen, although I guess they don't literally use the pen so much, but the prescribing that usually a physician, but in some cases others are doing. What are some of the main problems that you see with prescribing today?
Well, I would offer a variation on that theme. The most expensive drug is the drug that doesn't work. And for various reasons, we do a lot of silly things in healthcare that interfere with doing the right thing clinically for the patient, right? But if there was one metric that every healthcare executive or health plan executive should have at top of mind, I would think it's 30x, which is the ratio of what we spend on medication failure versus medications that work as intended. And medication therapy is massively complex. That's why it takes 5+ years to get a pharmacy degree. It's just a really complex field of medicine, and there's so much more that we know about pharmacology, pharmacokinetics, pharmacogenomics, and so much more that we know about data science than what gets integrated into the day-to-day care workflow. That's just a huge opportunity to do better and think more smartly about how we prescribe drugs. And everybody would agree that the cost of prescription drugs is one of the biggest challenges in facing healthcare, and that's true. Uh, but they're really thinking about it incorrectly if they're focused on the price per pill as opposed to the total cost of care, which includes the cost of medication failure and mitigating that wherever possible.
So it sounds like you've been able to quantify that and presumably have some ideas on root cause. I wonder, retrospectively, I'm not saying it's even easy to look at it, but you can do it. From a prospective standpoint, I think back to, there may be simplistic concept of people say, well, half of advertising money is wasted, but it's hard to know which half. So you have the general feeling that it works, but you don't know. I mean, on drugs, for sure, I don't think anybody wants to be prescribed something that doesn't work, and no prescriber wants to prescribe something that doesn't work either. So, what does it mean to actually do that optimization? Is it, I mean, this kind of ratio, is it because no one's paying attention or cares? What's the issue, and how do we solve it?
But that's where it becomes a data science problem, not a clinical problem, because you're right. No patient wants to take drugs that don't work. No prescriber wants to prescribe drugs that don't work. But the right people don't have the right information in front of them at the right time. And so that's part of the problem that we're solving for. I mean, it is known clinically, the science knows which drugs have a high risk of failure for various reasons that a drug can fail.
Mm-hmm.
Until somebody takes a comprehensive 360-degree view of the patient, including the 10 or 12 drugs they may be taking that are prescribed by 4 or 5 different prescribers, potentially, and filled at 3 or 4 different pharmacies, until somebody takes a step back and looks holistically at the whole patient. No one person has the information they need to optimize a medication regimen across all of those different risk vectors. And that requires a fairly sophisticated data science solution to aggregate all that information and data, put it in the hands of a clinical pharmacist who can play the role really of a care coordinator and a patient advocate, combined with their specialized training in pharmacology to make well-informed recommendations to prescribers that take this 360-degree patient view.
So what sort of information is brought to bear, and how does it affect the workflow? You talk about the pharmacist, the clinical pharmacist being the coordinator, but you know, how does that affect what the prescriber does? When does it come into play, and how do the prescribers perceive what's going on?
And so, I mean, there are lots of different reasons that a drug might work fine for you and not for me, or vice versa. And one of the largest and least engaged reasons is genetics.
Yeah,
There are over 200 drugs now where the clinical evidence is totally clear that a good portion of the population just doesn't metabolize that drug, quote, normally, or the way the majority do. Yet prescribers, for all intents and purposes, are completely blind to that data point. And so they're really, I mean, they're guessing and they're doing trial and error prescribing when there's no reason to need to do that. I mean, it's now cheap enough to do the genetic test and to find out, are you in the 30% of the population that doesn't metabolize a drug in the normal way or not, and make a better informed prescribing decision armed with that data. But it
so when you
takes,
say, I mean, that's usually, I think the FDA has a list of 300 or more drugs where I mean, it's on the label that you need to do this testing. So is the physicians just don't know about that? They don't read it. They don't have a mechanism to order it. There's no reimbursement.
yeah, they aren't generally aware of it. And physicians often don't get very much, if any, pharmacology training in
Yeah,
medical school. That they're not aware of the genetic risk. Oftentimes, even if they were aware, until now, there hasn't really been a scalable way to do the genetic testing, put that data in front of the prescribers.
yeah.
And so that's part of the innovation in our model, is that we bear all the cost and the risk of doing that. So we'll partner with a risk bearing entity and a value based model. We'll go manage medication failure risk in their population. We'll cover the cost of doing the DNA testing, of having a clinical pharmacist and do a comprehensive medication review and make those recommendations to the doctors in a way that's concise and actionable. I mean, one of the challenges is right now doctors spend less than 60 seconds discussing a new prescription with a patient.
Yeah.
So the reality is they just don't have the time to do anything close to a comprehensive medication review, even if they did have the training and the data necessary to do that, neither of which are available to them. So that's the gap that we fill with DecisionRx, is we do all that for them, and it's done at no cost to the patient, no cost to the plan, no cost to the provider. It's a free curbside consult, basically, from an expert pharmacist who's advising the prescriber how to make smarter decisions to manage medications. Once the prescribers realize the degree to which we're making it easier for them to deliver better care, they universally embrace this, because why wouldn't you, right? No prescriber wants to deliver poor care
Yeah.
and make bad prescribing decisions.
Now, a
And
challenge that the physicians often have is that they don't actually really see the feedback. They don't, the loop doesn't get closed. They don't really know if something worked or not in many instances. How does the prescriber know that, this optimization is actually working? Do they just see evidence of it in their financial reports? Does it show up in the clinical record? Is it something that they just notice the patients are, getting better and not coming back to them, or they're cured when they do?
it can be all of the above, and it's largely a function of what type of payment model or clinical setting a given doctor is in. If they're in an accountable care organization, for example, and there is actually alignment of economic incentives where doing the right thing clinically is also the most profitable thing for the provider,
Yeah,
then
we
they
like
can.
when that's the case, right?
I mean, that's the holy grail, right?
Yeah,
And in those settings, I mean, the doctors do and will see this directly in their pocketbook, basically, because it's been shown unequivocally at this point that doing medication optimization, informed by genetics and delivered by a pharmacist, it reduces the total cost of care in a Medicare age patient by over $300 per member per month. And so, on the order of 10% of the total cost of care
yeah.
can be can be reduced just by getting people off of the drugs that don't work and on the ones that do. And if you're in a risk-bearing model where you participate in those savings, like an ACO, I mean, that goes directly to your bottom line.
I
That's
want to come
probably
back to that in a minute because those numbers they're low. I won't say staggering because there are some staggering numbers in healthcare. Those are big numbers though. How I want to ask about how the offering has evolved because as you mentioned, it is very complicated what you're doing, and it's not just all of the data science and the presentation that's complicated. It's complicated the whole workflow, the physician's psyche, how the patients respond, the interaction with the payment methods, and so on. So, what have you learned along the way to get to where you are now, or was it just a perfect solution when you plopped it in?
well, I mean, one of the learnings is that patients appreciate and embrace this. That they love it because they feel heard, and it gives them some direct control over their care, basically, right? When we do our interventions, for example, for high risk patients that we know are taking drugs that have genetic risk or drug interaction risk, or all the different risk factors we look at, we're making recommendations for changes in a little over 50% of those patients.
Yeah.
And even the ones where we're not recommending any changes, we're essentially confirming that you're on the best regimen that you can be on. Your doctor is a genius. It gives them confidence in their regimen, confidence in their prescriber, and there are downstream benefits in terms of adherence and compliance, even when we're not recommending changes. So it just gives patients much more agency over their care, makes them feel heard to have this concierge pharmacist resource that they can consult with, and they report back. About 80% of them report that they found the process very helpful when they have had a chance to discuss it with their prescribers, and that goes up close to 100%. So it's strengthening alignment between the patient and the physician, which also has downstream benefits.
Yeah, you cite in your marketing materials this savings on a per member per month basis of $100 to $300, with presumably the 300, as you were just saying, was the Medicare, and 100 is probably the commercial
Right.
book of business, I'm guessing. And it's a very large number. So we talk about $300 to $3,600 per year. And you were just mentioning, sometimes you'll take your patient and you'll say they're fine, and then some patients don't take any drugs. So how do you get to a number like that, $300, per member per month initially, without making some very heroic assumptions or taking into account a lot of things that you don't really affect? That's my first question. And a follow up to that is this a sort of like a one-time reset where you get that type of savings, and then once somebody's optimized, they sort of continue along? Or is there an opportunity to continue to have a return on investment year after year with a given patient?
Yeah, great question. I'll answer the second one first. So it's both. It's a one-time and it's a perpetual benefit. So we do really two interventions. One is looking at the current med list that you're on, making recommendations to optimize that for genetic risk and other risk factors. So that's the acute problem that you currently face. But the second deliverable really is the comprehensive genetic report that has a lifetime benefit, and will show you, the 30 or 40 drugs that you don't metabolize the way most people do, and should probably always be avoided. And we do know that the savings that accrue from medication optimization aren't a one-time benefit. It's a perpetual benefit. Once you get somebody off of a drug that they can't take or won't take because it causes unbearable side effects, now you're actually treating the disease effectively, and the long-term costs of that increased efficacy are huge. But to the first part of the question, where the savings come from, this goes back to my 30x metric, right? And this comes from a study, the Watanabe study from a couple of years ago, where they looked at millions of claims, quantified the average cost of a primary care episode at about $1,000 in total cost of care. And they broke that down into three categories. So about 38% of the time, I think, if we go to the doctor and there are no prescriptions written, that costs about $300. About 37% of the time, there are one or more prescriptions written and they work exactly as intended. And that only adds an average of about $95 to the total cost of care. And so that's really the pharma spend, the prescription drug cost. But 25% of the time, 1 in 4 patients, they'll get one or more scripts written and they fail. Either they lack efficacy or they introduce new problems or both. And that adds $2,800 to the average cost. So it's, in other words, 30 times bigger problem, bigger spend on medication failure than what we spend on the medications that work. So, I mean, by all means, don't overpay for medications, but more importantly, don't ignore the 30 times
Yeah,
larger problem, which is are you prescribing the right pills in the first place? And there just aren't solutions that address that larger problem at scale prior to DecisionRx.
that's a refreshing kind of approach that you're bringing across. I'm wondering, that you put this package together, both the technology and of the ROI model for it, and the ability to work in the workflow and get good satisfaction all around. What has been your commercial approach, and what sort of success are you having in the commercial front, and where do you see the challenges of scaling?
Okay, so we deliver this solution strictly on a value-based care model where we bear all the risks. So we'll partner with risk-bearing entities. It could be an ACO, it could be a Medicare Advantage plan, or a self-funded employer plan. We'll go in and contract to manage medication failure across their whole population, which means every month we're ingesting all of their medical claims and prescription claims. We're risk stratifying the population to identify patients most likely to benefit from our intervention. And we do all the work to educate and inform and engage those high-risk patients in the program. Once they consent, we'll send a buccal swab kit to their home. They swab their cheek and send it to a lab. We put all that data in front of one of our clinical pharmacists, who then does the comprehensive medication review and makes recommendations to the prescribers in this 2 or 3 page medication action proposal that actually is practical for a prescriber to act on in the limited amount of time that they've got. And oftentimes, I mean, it really is about data and exposing risk signals that they would not otherwise see if they don't have the opportunity to step back and look at the whole patient and the full clinical record. We're exposing these risk signals. Once they see the data, the physicians overwhelmingly act on that data. 80 to 90% of the time, we know physicians will follow the advice of a pharmacist when they make these recommendations. So that's kind of the workflow. And then the business model innovation is the aspect where we can cover all the costs. So we've eliminated all the friction of the third party reimbursement system.
Yeah.
There are no claims going to a payer or to Medicare. There's no bill going to the patient. You don't have to worry about, is this going to be reimbursed by insurance? We just cover all that cost, and we only get paid from the savings that we know stem from this medication optimization process. And importantly, the peer-reviewed data on this show that those savings, they have nothing to do with drug spend. The savings are from avoidance of high-cost events, largely ER visits and hospital admissions. The change in pharma spend is not statistically significant in an intervention cohort versus a control cohort. All those savings, again, on the order of 10% of the total spend, they come from avoiding ER visits and hospital admissions.
Well, I think you'll make some friends in the pharmaceutical industry as you grow this. Take the heat off them and put it elsewhere. And it is actually interesting because the pharma companies will argue that their medication is actually effective in the total cost of care, say reducing emergency room visits and so on. And I think what you're saying is if properly prescribed, and in general, it doesn't necessarily mean less prescribing. It means a shift. That's very interesting. Okay, so I know my doctor doesn't have this yet because I haven't received a kit to do any testing. How many patients have you reached, or how do you think about how big how much penetration you've got so far?
Well, we just launched this earlier this year. We've got over 230,000 lives under contract at this point, mostly through accountable care organizations. And we announced in January of this year a credit facility with Carlyle Group, who's put up $100 million commitment to fund the delivery of these MTO interventions. And so we're getting scale really, really quickly. And I guess not surprisingly, because we're essentially eliminating all of the barriers to implement this program. We're not asking sponsors to pay anything or invest anything up front. We're incurring all that cost and taking all the risks. So there really is no excuse to continue settling for a trial and error prescribing program when for free, basically, we're able to give you a much smarter and more sophisticated approach.
It's like a frictionless approach. You should be able to, move along quickly. Although sometimes they say if there's no friction, there's no traction either. But it sounds like you've gotten rid of all the stuff that we don't want to have. It gets in the way of adoption. So that sounds very exciting. Well, we're going to keep an eye on this, Travis. Meanwhile, I want to close off by asking you if you have any book recommendations for our audience here, any books that you've read lately or whenever that you would recommend, or anything you'd recommend we stay away from in the name of optimizing our reading.
Wow, I wish I had more time to read for pleasure.
Yeah, we all do.
Yeah, the book I often tell entrepreneurs is the best entrepreneurship book you could read. It actually is not a business book at all. Mm-hmm. And I recently reread it for the third or fourth time, I think, is Endurance, the biography of Ernest Shackleton. Mm-hmm. I mean, it's not a business book, obviously, but if you're looking for a model of entrepreneurial leadership, tackling audacious goals in the face of impossible odds, I mean, it's hard to think of a better role model than Ernest Shackleton. So I would encourage every entrepreneur to read that book multiple times. That's
good. And have you read any books that caused like collateral damage that was 30 times the cost of the book, or?
No, our business plan illustrates that 30X for sure.
Sounds good. Well, Travis Morgan, President and Chief Financial Officer of DecisionRx, thanks for talking to me today about optimizing medication and so much more.
Thanks for having me.
You've been listening to the Health Biz Podcast with me, David Williams, President of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.